It's time to turn down the noise and tune in to this special edition of News You Can Use. Your host is Dr. Nick, the incrementalist, a longtime innovator exploring incremental changes across various industries that can be applied in healthcare. Combining the powers of observation and real-world experience, Dr. Nick makes the case that innovations in healthcare can be accomplished incrementally, not just by moonshot events. Now, here is Dr. Nick.
In this week's special edition of News You Can Use on Healthcare Now Radio, I sat down with Adolph Lombardi. He's an orthopedic surgeon who practices in New Albany, Ohio, to explore an introduction to total hip technology. Adolph, thanks for joining me on the show.
Well, thanks for having me. It's a pleasure to be here. I'm talking to you from New Albany, Ohio. I have been in practice in the greater Columbus area for the past 39 years. I actually started practice July of 1987. Let me tell you a little bit about myself. I was educated in Philadelphia. I went to Temple University School of Medicine. I did my orthopedic residency at Albert Einstein Medical Center in Philadelphia. And then I did 2 fellowships. I got very excited during my residency about joint replacement. And the reason I got excited is that those patients were happy after the operation. And you were doing something concrete to help them. You were using metal, plastic, ceramics to rebuild their hip or knee joint. And so I did a fellowship here in Columbus with my mentor, Tom Mallory. At that time, he was doing quite a few of these operations. We would do anywhere from 8 to 10 a day, which was unheard of at that time. We ran 2 ORs, and I got a great education. I spent 6 months with him, and then I went, because I didn't think I had enough, I went to the Washington, D.C. area to work with a gentleman named Jerry Yang. His brother, Andy Yang, was a big proponent of total hips and was one of the gurus, actual first ones to do some of the cementless hip replacements that now are just routine here in the United States. So I learned from Jerry how to do knees and Charlie how to do some hips. And my mentor, Tom Mallory, had invited me to come back. So I've been back in the greater Columbus community, now here in New Albany, just a suburb. And to date, ladies and gentlemen, I've done about 38,000 of these total joints. I specifically love total hips. And the reason I love total hips is that a journal that many orthopedic surgeons, Nick, don't read, the Lancet, published an article that this was the operation of the century. And indeed it is. When you do a total hip replacement, let me just explain to the viewers, what you're doing is you're taking the ball and socket. When we're born, we have beautiful lining cartilage on the acetabular side, the socket side, and the ball side, the femoral head. That cartilage gives us that freedom of motion. Unfortunately, as we age, there's probably a mechanical, a genetic component. We really don't understand how certain people have severe arthritis and others don't. That deteriorates. You start to get limited range of motion. You're unable to tie your shoe, get in and out of a car, and everything is painful. And when you do a hip replacement, on the acetabular side, you generally put in a metal shell and some type of liner. Today, we're using a highly cross-linked plastic polyethylene liner. When I started, it was not the same good material. And so the failure mechanisms have changed. I'm going to go through that with you in a minute. And on the femoral side, you put a metal stem into the thigh bone, the femur. Now,
So if I may, I think this is fantastic. Excellent sort of background, and I can't disagree with you even slightly in terms of the operation of the century. However you want to describe it, it is absolutely revolutionary. Before we get into where we've gotten to with the technology, I want to ask you a couple of things because, from my practice, back in that era, there were a couple of things, and you sort of touched on it. One was the cement, and that really became an issue in the redo because they wore down. They had about a 10 to 20 year life expectancy. And I think we've seen now an extension of that, but I'm not sure that we know what it is, although I refer to it as the 100-year hip based on the wear rates that we're seeing. What were the innovations that we got to before we started to move even more. I mean, we've already made some amazing progress, but those were the primary things in the early days, as I recall.
Correct. When I started, we had just started introducing cementless technology. My mentor had a cementless implant that we have reported on the actual 20-year survivorship, which was around 98%.
Because not everybody has the same background. Can you explain why cementless is so significant and why that was an important innovation?
Okay. So if you think about it, we use this material, polymethylmethacrylate bone cement. It is the strongest the day we put it in. It then will weaken with time. And the problem was there were certain things that were not fully understood, like how to pressurize the cement to get it to interlock into bone. Bone is a three-dimensional material. The way the cement bonds to bone is not like an adhesive, it interlocks into the bone. And then the metal rod you put in there has to bond to that. Well, initially we thought that, but then we learned that because cement is viscoelastic, meaning it moves slightly, we designed stems that had tapers in them.
Yep.
And then we designed them out of stainless steel. And then there came along with, oh, maybe we'll make it better with chrome cobalt, because titanium is a fiasco.
Yeah, right.
When you put in cement. It's a soft material, and it will rub and debride and cause significant wear. Now, at the same time we're having these struggles, we're having a struggle with the plastic because it wasn't high quality plastic, and we were putting a metal ball against that plastic. If we put a titanium ball, that was the worst fiasco, and we did some of those. We went then to hardening the surface of titanium, then to chrome cobalt, and thank God now we're at ceramic. And the initial ceramics were brittle. The current ceramic has a very, very indistinguishable fracture rate. I haven't had a fracture in 20 years of a ceramic head.
Right.
But when they do occur, they're a fiasco. So the combination today, what we have is a combination of a beautiful ceramic. It's actually pink in color. It's called Bilox Delta, on a highly cross-linked polyethylene that has an antioxidant, usually vitamin E, and a metallic shell that has a porous surface. So again, the three-dimensional surface bonds to the bone. The bone will grow into it. The cement, on the other hand, was an in-between, and it was a weak, it was the Achilles heel. It was going to...
So to be clear, no cement in that rearward-facing cut that sits in the acetabulum.
We are very rarely, you will
Right.
see this in Europe. In some of where you're from Great Britain, I understand, right?
Originally, yes.
Yeah. So our English colleagues will use cement, and will cement both the socket and the femoral stem.
Still to this day?
To this day,
wow.
There's an ongoing controversy as we talk about some of the problems. One of the problems we'll address right now that we can possibly have is a periprosthetic fracture. This means you put that metal rod down into the bone, and at some point it could be 6 months, it could be a year, it could be 2 weeks, the bone will break around the implant. Now, why is that? Well, if you look at the data, it occurs most frequently in the osteopenic elderly female,
right.
or the female who has a subcapital fracture, a femoral neck fracture, goes to the local emergency room and gets a cementless hip put in. And the argument in the United States is that our resident pool is not being trained as well as we used to in using cement, because the success of cementless has skyrocketed, and most of what they see as a resident is cementless technology. Now, there are some new versions of stems.
I just want to clarify something for the listeners, because I think it's important. When you hear things like that, you go, gosh, maybe I rethink it. But when you talk about that complication, that is a rare, very infrequent complication that occurs in hip replacement, correct?
Correct. I mean, we're talking about 1% or so,
right?
A very, very small number. But we're still working and addressing this as the orthopedic community. Just having returned from a meeting abroad, we had the European versus the U.S. kind of opinions. The Europeans are going to take that osteopenic female and probably cement in a tapered stainless steel stem. And the Americans are probably going to do what we call a collared stem. So you cut the bone, you put an implant in, and you have a collar that rests on the bone. And it's felt that that collar, and there's some finite element analysis that has been done that shows it decreases the strain and decreases that incidence of periprosthetic fracture. So we are keenly aware of it. We evaluate every patient individually
Right.
and decide. And I still will occasionally use the bone cement in some of those patients that I have a concern for.
Right. So to be clear, it's not it is a very small subset, but it is not something that the medical community ignores, and in fact is focused on. And we're going to talk about that in a little bit. Before we move on from this, one of the things that again used to be the case, and I don't know that everybody fully understands this, was we used to hold off on putting hips in until people were those elderly osteopenic individuals. My sense of it now, with the impressive progression of that technology, is that picking the right time is much more important, because you can get a long lifespan from that device. So you want to get it in early enough, as opposed to waiting till, for instance, a fracture, which to me is a catastrophic incident and doesn't improve your outcomes. Is that true? What are your feelings about timing and symptoms for patients who think about this?
Well, I tell every patient, I don't operate on an x-ray, I operate on you, the patient. I'm listening to your symptoms. I'm assessing the limitations. I'm assessing your impression of your quality of life. And so if the number of bad days outweigh the number of good days,
Right.
we have a great operation, and we have great implants. And as I expressed, good materials that are going to last you, I think, 25, 30 years. One of the things that my mentor, Charlie Eng, said, as I mentioned him earlier,
Yep.
is once you have biological fixation, once the bone grows into the implant, it doesn't loosen. It's the opposite of cement. It's a living, viable interface. And what you'll see that if that's going to break down is maybe that the bone shields because of the stiffness of the rod that you put in, but we're not seeing much of that anymore because we have different shapes. We're using more titanium. He was using a chrome cobalt, a very stiff material at that
Right.
time. So, so I feel what I tell my young patients is, yes, maybe 25, 30 years down the line, you might need another operation. I think that's going to be change of the plastic liner and a fresh new ball on the
Right.
femoral head.
Yeah. Very much so. I So you've talked a lot. I mean, let's be clear. I think outstanding operation, one that is increasingly something to consider earlier, and as you rightly say, based on the patient's symptoms, not based on clinical X-rays. You talked a little bit about complications with the periprosthetic fracture. Any other issues that people should be concerned about, or at least understand as a possible thing, and what are we doing about them?
Yeah, let's talk a little bit about the number two, actually, which is actually the number one, and that's periprosthetic infection. And I will say you, the patient, can do some things to help prevent infection as well. I mean, no orthopedic surgeon, no surgeon at all wants to deal or is happy about infection.
Right.
This is the worst nightmare I face.
Yep.
So I want to start. There are three ways for us to approach infection. We're never going to make it zero, but we're going to start with pre-op, right?
Yep.
If you're a smoker, stop smoking. Give me at least 6 weeks of smoking cessation. If you do that, you're helping yourself and me decrease that incidence of infection. If you have poor dentition, get to the dentist.
Right.
Get things cleaned up first.
Yep.
If you're struggling with diabetes, then you need to get on the right medications. You need to get optimized. You need to get that hemoglobin A1C down way below 7. And, if you're a little overweight, dieting is good. Doing some pre-op exercise is good so that you're mobile. So this concept of patient optimization has come to vogue in the past 10 years as we've shifted from what I say operating on a sick patient to operating on a healthy patient. And remember, 98% of my patients today are home within 4 hours of the operation. That's because we've optimized you before the operation, and we have learned how to deal with post-op pain control, and we want early ambulation. What does early ambulation do? It prevents the infamous DVT, blood clot. Nobody wants a blood clot. So if we do all these things, we can minimize infection pre-op. The other thing we can do is we do things such as a chlorhexidine. It's a topical agent we use over the skin. We give you actually that to shower with the night before. We can decolonize our nasal cavities, carry a lot of bacteria.
Yeah.
We can do an iodine swab in the pre-op holding area to decolonize that, prevent that. So there are multiple things, or a nutrition bundle if we need to.
Yeah.
And then during the operation, we use a lot of irrigation, saline, and we can use a dilute betadine solution. And then obviously perioperative antibiotics. And if you're in a high-risk category, perhaps you're a little bit overweight, we may do extended antibiotics.
Yeah.
And then, so these are the things that we try to do, as well as making sure we have new dressings now that we apply. For example, in our heavier patients, we use dressings that are called wound vacs, a negative pressure dressing to pull have the wound heal from deep to superficial, and any seepage that would come out in a heavier patient that will be collected into a vacuum and discarded. So there are many things we're trying to do to prevent infection. Some of the newer things that will be available to us, I think, in the future. For example, right now, our Japanese colleagues are using implants that are coated with iodine. Now, they can do that in their country. We have the FDA here,
Right.
and we're going to have to go through some hoops to get that approved. But I think once we get some good data out of Japan, we'll probably start looking more aggressively at that with the FDA and hopefully get that approved.
Yeah. So I mean, I think it just reaffirms my experience. And to be clear, 40 years ago, this was a primary issue, because when I worked with my orthopedic surgeon and was in the, it was night and day in terms of the rigorousness and the severity of the approach to cleanliness from the orthopedic surgeon relative to others. I mean, it was very clear, and for all the reasons that you described, because obviously infection in that circumstance is very challenging to deal with. For the purposes of time, I want to focus a little bit on the future and some of the things that are happening. And I know that you're working on a trial that is sort of testing out new technology. And again, I have to make this point because it's important to me, and I think for the listeners to hear. This is such an outstanding operation, if you need it, clearly. But for those people, this is fantastic technology. But once again, medicine doesn't stand still, and we're trying to improve it. What are you doing addressing the future and thinking about it? You talked about the iodine in the case of Japan, and incorporating that. What else is going on, and what are you working on?
All right, so we've talked about periprosthetic fracture, periprosthetic infection. Now we have to talk about the other thing that we dread, and the patients will come in and ask me if this is going to happen, and that is a postoperative dislocation, where the ball comes out of the socket. Again, I want to make sure we emphasize these are all rare. We're talking low percentage. Infection is usually less than 1%. Periprosthetic around the same. And dislocation is today, sometimes it's approach dependent. The big thing today is anterior approach versus posterior approach. Many of my patients are coming in saying, Adolph, you're going to do an anterior approach. Of course, that's what I'll do. I've never done a posterior approach personally. I've done many lateral approaches, which is a very stable approach, helping keep that ball in place. The anterior approach, also a fair amount of literature showing that it is more stable than a posterior approach. So what are we doing for stability? Let's talk about that. Let's talk about two aspects. One is technology, okay? Today, with the advancement of AI incorporated into robotics, we can actually get a 3D scan of your hip and model it to see where it's going to impinge. Impinge means where it's going to touch the bone and come out of socket. Um, so, and then decide perhaps the exact orientation that we want to put that metallic shell in with that plastic liner and that stem with the ceramic ball. Now, a new implant that has hit the market is something called the reverse hip. Many of you here may have heard of the reverse shoulder because it's been around for a number of years. And I'll tell you that when it came to market, there were a lot of naysayers. Interestingly enough, it's about 85% of the shoulders done today. And why is that? It is extremely stable. So if we look at the hip, there's this reverse hip models after the reverse shoulder. We, on the socket side, we're going to put the metal shell and we're going to put the ball in the socket. On the femoral side, we're going to put the metal rod in and the cup there. With doing that, we increase the surface area and the range of motion. I actually saw this in a lab 6 to 8 years ago and told the company I was working with at the time, we should look into this technology. Well, they decided not to. And then I got invited to be part of the IDE study, which is a randomized study. If you want to believe something, you have to look at a randomized study where I tell the patient, this is a device. My research assistant comes in and talks to them, signs them up. And then the day of surgery is when I find out if they're getting a reverse hip or a standard hip. That's how you can tell if something really works. And so I've been privileged to do that. And I've enrolled over 35 patients in it now. I have data that comes out of Canada by a Dr. Turgeon, RSA data. RSA is a special type of X-ray data that shows us how the implant is doing. Is it moving? So when you implant these devices, we want to make sure they're stable. And the RSA data is showing less than 0.08 millimeters of motion at 2 years and now even at 5 years follow-up. That,
and relative
is excellent.
Relative to existing technology, how does that rank? So
it's equivalent, if not better. It's to
right.
Existing.
Okay.
Anything you put in is going to move slightly. 0.2 millimeters is the cutoff. Right. This is 0.08. So
right. So
we know it's a stable construct.
A tenth or 100th even of what we've seen in other instances, which is still normal, but much less.
So, but the key feature of this is once you put it in, you can take that hip through a range of motion, and it doesn't dislocate. And we have seen this in the lab. We have seen it in the OR. So I have been expanding my indications and enrolling more patients. The study's going on at multiple centers in the United States. I do think this is going to bring an added technology to our armamentarium, something that will really help us perhaps eliminate this problem. And the patients that are at significant risk are the spinal pelvic fuse type patients, the ones that have had massive spine surgery all the way down to the pelvis. They don't flex their pelvis like one who's not. So that stiff spine needs an extra stability. Now, there are other constructs that are used to help this, one called dual mobility, which is a double motion cup, but it's not without dislocation either.
So just to summarize, there's an ongoing trial that is looking at, and I'm going to use the term you used, a reverse hip, which we'll put in the details in the notes for this, and maybe we can get some diagrams to actually show what this means, because I'm even confused because it's difficult to sort of picture without actual images. And the trial is currently undergoing. You have multiple centers. You're one of the centers. People can reach out, find out about it. Obviously, with multi-centers, they don't have to travel to Ohio. So there's an opportunity to sign up. And the primary endpoint, am I right in understanding this, is a reduction in instability or the potential for instability in the future. Is that a fair summary?
Yeah, this is what we're after.
Yeah.
We're after a very stable construct, and we're getting it with this device. And we know that it gets the fixation, because that was what was most criticized. Are you going to be, those forces that are generated, are they going to make that cup move? And it's not happening. The RSA data is concrete. And my clinical data so far, patients are very, very happy. I can't tell the difference between my standard and my reverse hip patients. Right. Neither can they. So, but so I have a lot of confidence in this device, and would suggest that if you have any concerns, look into it.
Right. All right. Unfortunately, as we do each and every week, we've run out of time. Fascinating subject. I think anybody that knows me knows this is, very personal to me individually. I've had the benefit of this technology, and a big advocate for hip replacement, and obviously the innovation that we're bringing to bear and addressing, albeit a minority of cases that have challenges with complications, which, let's be clear, that's the case across the whole of medicine, irrespective of what we're looking at. We are always dealing with challenges, but they've been reduced to extraordinarily low numbers. And even today, we continue to advance, and there is an opportunity. So for those of you that are interested, you can learn more about this at hipinnovationtechnology.com, which is where details of that particular innovation, the trial that's ongoing, and Dr. Lombardi. It just remains for me to thank you, Dr. Lombardi, for joining me on the show, sharing all of the details, all of the excitement, quite frankly, with this operation, the opportunity for people, and explaining the details so that everyone can understand. Adolph, thanks for joining me today.
Thank you, Dr. Nick.